We are here together today to learn some about eating disorders and really looking forward to this talk. I just have a few quick announcements to make. This is our last ED series of the year. And we will be working on our schedule for 2025 very soon. So please let us know if you're interested in presenting on a specific topic, or if you have requests for certain topics. You can just email us at info@mhaspartanburg.org. The next big event that we have besides our ED series will be our Be Kind to Your Mind event on May 3rd here at the Northside Harvest Park. We are always very excited about that event to raise awareness for mental health issues. So please be taking a look on our website for those. We also should have a new executive director by the end of this year, starting January 1st. And so we're excited about that. We'll be announcing that shortly. If you have any general questions or concerns, of course, email the info@mhaspartanburg.org. The CE process there is a link and a QR code. I'm going to put it in the chat for you. So please take a look at that if you're interested in getting the CE credits for today. So now I have the pleasure of introducing our speaker today, who is Elisha Contner Wilkins. She is a licensed marriage and family therapist. She is a certified eating disorder specialist consultant. She has approximately 25 years of experience in behavioral health, working with children, adolescents, adults, and families. She has focused most of her career on working exclusively with eating disorders, and has held various clinical and leadership positions at all levels of care. She's been instrumental in launching eating disorder programs in both Florida and Virginia. She has specialized training in cognitive behavioral therapy, dialectical behavior therapy, family-based treatment, and mindfulness. She has provided supervision and training for those pursuing state licensure, in addition to certification with the International Association of Eating Disorder Professionals, IAEDP. She founded and served as the inaugural president of the Richmond IAEDP chapter, served on the IAEDP National Board as a chapter representative in 2021, and of course has volunteered with the Eating Disorders Coalition to support advocacy efforts. She also serves on the board of trustees for Elk Hill, which is an organization that provides specialized education, community-based services, and residential treatment programs for youth in Virginia. She is also presented at local and national conferences. Elisha is passionate about ensuring that clients have access to care and at the most appropriate level of care, believes the full recovery is possible. She also enjoys educating and coaching family members and loved ones, as well as supervising and mentoring the next generation of eating disorders professionals. Welcome, Elisha. Thank you so much.
Thank you, Maggie, for the warm welcome. I'd also like to introduce my colleague, Ryan Sobis. We have been traveling around the Greenville-Spartanburg area for the last couple of days, so it's been a pleasure. We're glad to welcome all of you today on this nasty rainy day to our Eating Disorders 101 presentation. I'm going to turn it over to Ryan. Ryan works in marketing and outreach, and she is going to tell you a little bit about our program Within Health.
Hi, everyone. Thank you so much for joining us this morning. As Elisha mentioned, my name is Ryan Sobis, and I serve as the clinical outreach representative here at Within Health. I'm actually a Converse grad, so being back here in Spartanburg has been so much fun for me, and I'm excited to have you all here and to join us. For those of you who are just getting familiar to Within Health, I thought I might take a moment to share a little bit about our program, and then we will dive into the really important topic of eating disorder care. What stands out to me the most about Within Health's difference is our ability to create a patient-centered care experience. Because we are a national organization, when we have someone entering our admissions process, we're able to identify not only their eating disorder diagnosis, but also any comorbid diagnoses that are existing. And we can build out a hand-selected treatment team that's going to individually meet their needs. We can select providers that are going to be experts in kind of how they're identifying with their eating disorder, as well as is in line with kind of whatever demographic presentation they're presenting with. Once we have that individual treatment team established, we can then carve out a treatment path forward. We do not have standard treatment hours, so our program can wrap around a patient's schedule and can be really individualized to navigate whatever school or work challenges might exist. We're also to be able to create therapy groups that are going to provide and foster a milieu of connection that really resonates with how that patient's identifying. The next thing that I will say is Within Health is the first fully comprehensive remote PHP plus and IOP plus eating disorder treatment program. And when I talk about our care being remote, most of the providers that have been in our care have worked in traditional treatment centers before and thought critically around how can we create a patient care experience in their home. And so the first thing that we do is we provide meals, up to 2 meals a day that are shipped to our clients. We are also able to provide a numberless scale, a blood pressure cuff, and a thermometer so that their registered nurse is able to conduct remote medical monitoring. So being very thoughtful around how can we make care accessible. Within Health has their own app that they've created, and so treatment comes to the patient on their phones. And it's our way of being able to work through many of the barriers that folks face when they are trying to access eating disorder support.
All right, well, I'm gonna take it back over, and just let's talk a little bit about some of the basics of what is an eating disorder, and then we're gonna get into some of the diagnoses as well, so that you all have some of the basic information should someone with an eating disorder walk into your office, or somebody perhaps even consults with you. So an eating disorder is a biologically based mental illness. We know that it's a very comprehensive illness, and I want you to focus in on that word, that it is an illness. It's very complex. There are emotional, medical, nutritional complications as well. It's also a disorder that's rooted in stress and anxiety, and we know that many of our patients will develop an eating disorder because it becomes a way for them to emotionally regulate. It becomes a way for them to manage stress and anxiety in their life. We also know that they're growing cognitions, the cognitive distortions that maintain the behaviors. So some of that negative self-talk does reinforce some of the behaviors. And not only is some of that internal, but some of that is also external. So they may have individuals in their lives who are unintentionally saying things that do reinforce the eating disorder. And as I mentioned, it is something that does reinforce itself over and over and over again. It is difficult for someone to stop the eating disorder behaviors because, again, they are so internal, and it becomes a way to regulate emotions, and they see that it is something that works. So even if somebody wants to stop the eating disorder, treatment is necessary in order for them to do that as well. Very often we'll hear parents or loved ones say, I don't understand, why they just can't stop this. And again, because it is something that is rooted so deeply in them, and we have to peel back some of the layers to really get to the core issues, the root of the eating disorder, why it started in the first place, and what is actually maintaining the eating disorder. And it is a life-threatening illness that really does require a support network to work from. With an eating disorder, somebody in the United States dies every 52 minutes. So basically every hour, someone in the United States is passing away from an eating disorder as well. So it is a life-threatening illness that does require a full team to recover from. Let's talk about the first diagnosis, anorexia nervosa. Typically, when individuals think of eating disorders, this is typically what people think of as well. Some of the diagnostic criteria that we are going to review comes from the Diagnostic and Statistical Manual of Mental Disorders. a new version, the DSM-5, came out in 2013. And some of the criteria to diagnose an eating disorder were changed. And that's really in favor of individuals getting treatment. So with less criteria needed to make some of these diagnoses, more individuals are able to access care, as Ryan was talking about, and able to get treatment as well. So I'm not going to go through all of these, but I'm really going to just focus on the pieces here that we see in bold. So with anorexia, there is a significant reduction of intake that leads to low body weight. So we want to also take a look at someone's body mass index. We also want to take a look at their percent to ideal body weight. And for those under the age of 20, we also want to obtain growth charts and look at their growth charts for height and weight as well. So we can continue to look at what trajectory we want to ensure that they are on in order to be set up to be successful later on in life. Individuals with anorexia also have a preoccupation with size and shape and body image. They have a disturbance with the way that their body is experienced. So one of the questions that they might be asked in the intake process is, what percent of the day do you spend thinking about food, weight, or shape as well? And they've also got an intense fear of weight gain. What was removed from this diagnosis is there used to be an absence of one's menstrual cycle, and that has since been removed because over decades, we are seeing more and more males who are impacted by anorexia as well. With bulimia nervosa, this is probably another one that you all have heard of as well. This is where we see recurrent episodes of binge eating. So what is a binge? A binge is typically defined as during a 2-hour period of time, one consumes more food than one normally would consume under the same conditions, under the same circumstances. And when we talk about binge eating disorder, we'll get into some more specifics as well. But also associated with bulimia nervosa, not only do we see binge eating, but we also see what we call compensatory behavior. So if you focus in on that word compensatory, how does one compensate for the binge eating? So one may compensate for what they consumed by purging through vomiting. They may be engaging in laxative use, diet pills, water pills. They may also be restricting or fasting. So we may see individuals engage in these cycles of binge eating and then periods of restriction and fasting. Or one may engage in compulsive exercise as well. We also know with bulimia that self-evaluation is unduly influenced as well by body weight and shape. And then with binge eating disorder, this is actually one of the most common eating disorders that we see now. Approximately 2.8 million individuals in the United States are impacted by binge eating disorder. This became its own diagnosis in the DSM-5, as I mentioned, that came out in 2013 as well. So we see those recurrent episodes of binge eating, and the binge eating occurs on average at least one time a week for 3 months. And prior to the DSM-5, the binge eating episodes did have to occur on a more frequent basis. However, this was not its own diagnosis. It fell under what we call the eating disorder not otherwise specified. So the binge eating episodes are associated with 3 or more of the following characteristics. Individuals may eat more rapidly than normal. They may eat food when they're not physically hungry. So one of the things that we want to do as clinicians is distinguish between, is this physical hunger or is this emotional hunger? They may eat to the point that they are uncomfortably full, and often eating episodes are followed by feelings of guilt and shame, feelings of disgust with oneself, depression, and they're often eating alone. So many of the binge episodes are happening in isolation as well, because there is marked distress regarding the binge eating as well. And then, as I mentioned, with binge eating disorder, that is the most common eating disorder, one of the most common eating disorders, I should say, that we see. It is newer. It's the least researched eating disorder diagnosis. And what happens is I was talking before about those cycles of binge eating and then followed by restriction. So when individuals restrict food, that can also set up that binge restrict cycle for those individuals that are vulnerable as well. And then half of all patients with anorexia will go on to experience binge eating disorder. I like to say that sometimes the pendulum will swing the other way. So when an individual has been engaging in symptoms of anorexia, very often later on in the course of their eating disorder, they will swing to the binge eating episodes. And that's just due to some of the energy restriction. And then we also have, this is kind of our catch-all, otherwise specified feeding or eating disorder, otherwise known as OSFED. This is also one of the most common eating disorders. So what we will see under the criteria of OSFED is we may see individuals with what we call atypical anorexia. So these are individuals who are engaging in the diagnostic criteria that we saw previously for anorexia nervosa. However, these individuals are not necessarily significantly underweight. We also may see episodes of bulimia. However, they're not engaging in those behaviors once a week. Maybe it happens to be every other week or every 3 weeks. So it is a low frequency or it's a limited duration. It may not be that 3-month criteria that we saw previously. Again, we may also see binge eating disorder episodes, exactly the same with the lower frequency or limited duration. And then we may also see purging disorder. So this is where individuals are purging, engaging in those compensatory behaviors. However, they're not engaging in binge episodes. And then I'm going to turn it over to Ryan for orthorexia.
Yeah, orthorexia is an interesting presentation in the eating disorder field. You know, it isn't necessarily its own DSM-5 diagnosis. What we will often see with orthorexia is this kind of hallmark association of morality attached to food choices. And so we will find this often as someone is maybe recovering from anorexia. They may be working on some of the weight restoration aspect. However, they're not quite ready to let go of their food rules. They may be very attached to eating perfectly or eating cleanly. Oftentimes this can lead to a lot of isolation. Someone who may be preoccupied with preparing their own food, or they're unable to engage in social situations because they're not comfortable with how the food might be prepared or what might be available. And so this actually can lead to kind of its own food restriction if there are not macronutrients that are available that are kind of unnecessarily cut out because someone isn't comfortable with that food that's there. And so I would say that one of the major presentations of orthorexia are going to be those feelings of guilt or shame when they're not able to adhere to those really strict food rules.
Another diagnosis that also was newer in the DSM-5 in 2013 is what we call avoidant restrictive food intake disorder, otherwise known as ARFID. I know that's a little bit of a mouthful. Prior to the DSM-5, some of this criteria fell under the category of feeding disorders in infancy and early childhood. And so prior to 2013, some of this criteria was limited to those under the age of 6. So there are a number of individuals who were unable to get treatment because there was no diagnosis of ARFID as well. So now ARFID can be diagnosed in anyone. What we see sometimes is significant weight loss or failure to achieve expected weight gain or growth in children. So again, that's why getting growth charts is important. Individuals with ARFID may not also be in a situation in which they need to weight restore. They may be of normal weight as well. If they are in that phase of where they've lost a significant amount of weight, regardless of the weight, we want to also look at and determine if there are any nutritional deficiencies. And if there are, we would want to first ensure that we are focused on weight restoration and that we are focused on those nutritional deficiencies as well in the restoration of that. Sometimes you may see a patient come into your office and are really dependent on tube feedings or supplements for much of their energy needs, their caloric intake. In the event that the individual has not lost a significant amount of weight, they are of normal weight or even slightly above, and they're not showing signs of any of those nutritional deficiencies. The other thing that may signal to us that perhaps we are dealing with a diagnosis of ARFID is that we may see a marked interference in psychosocial functioning. So there may be significant isolation. Very often individuals with ARFID are limited to some foods. They may have a repertoire where they are only consuming 7 foods perhaps as well. So it makes it very difficult for them to engage with peers, hold down a job, manage school, go out with friends, go out with family, travel. So they really do become very isolated as well in their disorder. And that becomes part of what we focus on in treatment as well. Okay, sorry. I don't know what just happened there. We had a repeat of a couple slides, so I apologize for that unless I hit the wrong things. So when a patient comes in for treatment for an eating disorder, one of the things I just really want to highlight is we are not solely treating an eating disorder. There is a comorbid mental illness in which we are dealing with. Now, sometimes we want to look at which came first. Did the anxiety come first? Depression come first, and then the eating disorder became a way to manage that. Or what we also know about eating disorders is that sometimes because of restriction, because of malnutrition, because of the cognitive distortions that we see with some of the diagnoses, sometimes the anxiety and depression follows. So we do see a very high correlation with eating disorders, anxiety and depression, and obsessive compulsive disorder. This is just a very short list. We also see a high correlation sometimes with our adult population with substance use and abuse. And then we also see some comorbidities with other diagnoses such as ADHD, autism spectrum disorder. We may see that more commonly associated with the ARFID diagnosis that we saw previously. So just remember that when someone comes into your setting or into your office with an eating disorder, not only are you going to be managing and treating the eating disorder, you're going to be treating another diagnosis or diagnoses as well.
So we think of the eating disorders as the perfect storm. And the reason we use that terminology is because it is biopsychosocial in nature. You know, from a biologic standpoint, we often see eating disorders exist in family systems. You know, just because someone and a family member has an eating disorder is not a guarantee that their next generation will also have an eating disorder. However, when we are working with the patient, we will often find eating disorders kind of interwoven within the family genetics. And it's something that we have to address as a whole family and as a family unit. I would also say from a biological perspective, eating disorders are brain-based illnesses. And as we go in the slides forward, we'll find how there's a lot of research to support that the behaviors of an eating disorder, especially with food restriction, is going to have an impact on perpetuating this disease itself and comes with a host of medical complications that have to be taken into consideration. From a psychological perspective, you know, we think of eating disorders as a pattern of behavior, perseveration of thought that leads to some type of impairment. And so that perseveration of thought piece lends itself to recognize that our patients are spending a tremendous amount of time thinking of body weight and shape, as well as thinking about food, to the point where it interferes with their ability to be able to.
So sorry.
You're fine.
I was. Do I get it? No, I don't want to reclaim.
And from a social standpoint, an eating disorder can also lead to isolation. You know, patients who are often removing themselves from any kind of social interaction because they're unable to maintain their food goals. And so it leads to this kind of perfect storm of all of these three things that require a multidisciplinary approach when we're thinking of how are we going to support this patient's treatment.
So wolf in sheep's clothing, as we talked about before. Okay, we talked about eating disorders being, a life-threatening illness. And it is a serious condition that it can impact one's mental and physical health, and that in and of itself can be life-threatening. Sometimes individuals who, maybe are dealing with some restriction, who have not been diagnosed with an eating disorder yet, might first present to their primary care provider's office, their pediatrician's office. So this is one of the reasons why we like to provide this basic education to individuals as well, because we never know who the first individual is going to be, who's going to come into contact with someone and be able to diagnose this with an eating disorder so they can get the treatment that they need. Eating disorders have the second highest mortality rate of any psychiatric illness. That is followed by the opioid crisis. Eating disorders actually used to have the highest mortality rate of any mental illness. But again, keep in mind that this is higher than depression, schizophrenia, or bipolar disorder. And what we also see, and this would be a whole other talk, is that money that goes to research for eating disorders is actually less than is used for depression and schizophrenia, et cetera, as well. So, just keep all of that in mind as well. We see medical complications really is the most common thing that we see with eating disorders, and that's followed by suicide. And sometimes that can be suddenly and without warning. And the mortality rate is 12 times higher than the general population for females ages 15 to 24. One of the other things I want to point out is, keep in mind, as we talked about before, that someone with an eating disorder dies every 52 minutes. I want to also point out that the average age of onset for an eating disorder is the age of 12. And when I first started in the field, the average age of onset was between 16 and 20. And we're continuing to see that number go lower and lower as well. And so, that's.
Okay. When we think about the biological impact of an eating disorder, we can kind of take a look at how starvation and malnutrition is actually going to impact the brain. And we do have to take into consideration, not only when someone is struggling, it isn't about just eating again. We have to take these medical complications into consideration, even as we are in the process of reintroducing food, which is why medical monitoring is crucial. We'll take a look at how to safely weight restore someone based on lab values, based on kind of weight history, and being able to monitor that process pretty closely. We're also going to take a look at how the brain is impacted by an eating disorder with some of the studies that we have coming up in future slides. And, with a medical component, with a psychological component, with a family-based component, and with the isolation piece and needing that kind of rapport and engagement, we can see that all members of the treatment team are going to be crucial in having consistent communication and wraparound care of how we're going to mobilize this patient forward.
And as Ryan mentioned early on when she was talking a little bit about within health, is that treatment is multidisciplinary. I don't know if y'all can see my hands kind of held together in a ball. But when someone first comes in for treatment, everything about the eating disorder, because it is such a complex illness, is lumped together. And this is why we need a team of professionals treating an individual with an eating disorder, because we've got to pull out the medical piece, and we need the primary care provider or the pediatrician to medically monitor the body. We need the psychiatrist to diagnose, perhaps the eating disorder, but also some of the comorbidities that we talked about before, and they will determine if there is a need for any type of medication management. And then we have the therapist who's really getting to the function of the eating disorder and is also providing the individual, the family therapy, the group therapy as well. So we can help to understand, what is the function of the eating disorder and how is the eating disorder being manifested in so many other ways. We've got the dietitian who, if a client needs weight restoration, we'll work with them on weight restoration. A client may just need weight stabilization. A client may need a cessation of eating disorder behaviors. So the dietitian will help with patient learn to refuel their body with meal planning and will determine the energy needs for the client. We'll talk about higher levels of care on another slide as well, so I'll skip over that for now. We also need a nurse involved. So at Within Health, our nurse is meeting with our client anywhere from 1 to 3 times a week for what we call a physio check. And the nurse is monitoring the vital signs, they are monitoring the client's weight, and then they are also collaborating with the primary care provider or the pediatrician, who is somebody that is out in the community. So there is, in general, as you can see, a lot of collaboration that happens. And then I would be remiss if I did not talk about our wonderful care partners. These are individuals who spend time with our patients all day long. They do meal coaching, so they are offering support to our clients at meals. And they also manage some of those other resources that Ryan talked about that we have, which is what makes our program a partial hospitalization plus or an intensive outpatient plus. Is that our care partners are monitoring what we call the living room, and that is a place that clients can go to receive support on days that they're not in programming or between sessions or groups or meals as well. So again, collaboration is key. And that's one of the great things about working in a treatment setting, is that we have access to all of these individuals that you see on the screen all day long. Every single person that makes up our team plays a very important role in helping the client work towards the recovery process. And then collaboration, as I mentioned, really is key, and it is essential for providing that comprehensive, consistent, and personalized care, especially that we are able to do at Within, because it's very important that we are addressing all facets of the eating disorder. And I had mentioned when we were doing a talk yesterday that sometimes what the primary target is for that client, that could change on a daily basis, that could change on an hourly basis, that could change on a weekly basis, because sometimes we might see some signs of medical instability starting to crop up, and then it's like, oh, whoa, they got to get with the nurse, or we got to start collaborating more and talking more with their primary care provider, who might be instrumental in helping to make other treatment recommendations if we need to do that. Sometimes the focus might be on meal completion. So maybe the care partner and the dietitian for that particular day or for that particular week are really playing more of a primary role as well. So we tend to see a lot of ebb and flow as well. But again, all of this collaboration is really key in a successful and sustained recovery for our patients. All right, here's where we're going to talk a little bit about the levels of care. If you're not familiar with the American Psychiatric Association guidelines for the levels of care in eating disorder treatment, that's certainly something that you can get online. So we see everything from the inpatient level of care. That would be a level of care to which we might refer a patient should they need that 24/7 medical monitoring and stabilization. So for some, that might be where they go first for that stabilization. A step down from that would be residential care. That is also where 24-hour support and care is provided, but they are medically stable at this point, and they're not getting that around the clock medical care and medical monitoring as well. Partial hospitalization is what we offer at Within Health. This is a step down from residential care for some. And this is where, depending on their insurance, they're getting anywhere from 5 to 6 hours of care per day. And at Within, that could be anywhere from 5, 6, or 7 days a week as well. So it's still intensive treatment. At Within, they would be doing 2 meals and 1 snack per day. And then they also have a high number of touch points with their individual providers. So they would be meeting with their therapist 3 times a week and then meeting with their dietitian once a week as well. And then the intensive outpatient level of care is something, again, that we also offer at Within Health. This is where clients are getting 3 hours of daily care, anywhere from 3, 4, or 5 days a week as well. 1 meal, 1 snack. And again, they're still getting a high number of touch points with their individual provider. And so that's why we like to call it the plus. And they still have access to some of those other services that we talked about before, such as the living room. So even on a day that they're not in the program, they can still go to the living room and get support. Maybe they need additional support around a meal. They can take their lunch and go to the living room. A care partner is there readily available to have a meal with the client as well. And then outpatient is kind of this is where some patients may start for treatment, but this is kind of where a lot of the deeper work is done. This is where a patient is meeting with their therapist for 1 weekly session. They're also collaborating and meeting with their dietitian, their psychiatrist, as well as their primary care provider and pediatrician. And how often that happens will be determined by collaboration with the team. All right, I'm not going to spend too much time on this, just because I know we have many, many more slides to get through as well. This is a really neat and interesting study that came out in 1944. Believe it or not, it's the Minnesota Starvation Experiment. It is also known as the Keys Study. And this took into account 36 male subjects. So the male subjects were able to engage in this experiment in lieu of going off to war. So they got to, well, we'll go through this in a minute. To engage in the study, they had to be in good physical condition and of sound mind. But one of the things that Keys wanted to study in this experiment is what happens when we cut in half someone's daily food rations. So they observed the individuals first on a normal diet for the first 3 months, and they were at 3,200 calories. And then they split that in half for the next 6 months and put these participants, the male subjects, into a state of semi-starvation. Studied that. We'll talk a little bit on the next slide about some of the impact that was observed and studied. And then for the very last 3 months, they then started to increase and start to rehabilitate the males in the study as well. And then they also observed what that looked like as well. So this required a full year of participation. So what were some of their findings? Think about sometimes like maybe you don't get to eat lunch at your regular time and kind of how you start to feel, you know, maybe if your lunch gets postponed by a couple hours on a given day. I know I start to feel maybe a little lightheaded or maybe a little bit more irritable as well. So imagine doing that over a 6-month period of time. So what they saw was a decrease in strength and stamina. They also saw medical changes. So change in body temperature, heart rate, metabolic rate, because what we know is our bodies are really, really smart and our bodies are like a thermostat. And so when our bodies kind of dip below our required energy needs, things start to shut down. Things start to slow down as well to conserve some of that energy. They also found a food obsession. Individuals were having dreams about food. They were talking about food. Think of when you've like been sick before and you're not on your normal intake of food. I've also heard individuals say, yeah, gosh, you know, I saw a commercial about food and I was just like dreaming about what I saw on TV and I couldn't wait to get over my illness because I wanted to eat those things again. There's a lot of fatigue and irritability and depression. They also saw that. They also saw some reports of self-harm and individuals who also became suicidal as a result of the significant reduction in intake. It was harder to concentrate. It was difficult to have any insight or judgment. And then what they saw in that refeeding phase for those last 3 months were individuals, again, think back to when I kind of talked about that pendulum swinging. So they did see that refeeding phase, including some extreme overeating as well as continued preoccupation with food. So I'd encourage you to go ahead and, look up this study, and you'll just see the emotional, the psychological, the medical, and the nutritional effects of the semi-starvation.
I'm sorry, there are a couple of chat messages for whatever reason. The mistake earlier was because I couldn't log in.
Oh,
It took back over, so
okay.
I can't see what those chat messages are.
Oh, I'm sorry.
So no, and you may want to wait till the very end, but I just wanted to
I
make
don't
you
see
aware.
any messages.
If you go to the far right on the top, is there
Oh.
not?
Oh, more. Oh, Q&A. Sorry about that.
Yeah, I'm sorry. With this Zoom webinar, we have both.
Oh, that's great. We're gonna talk about mature adults.
We will come back
So
to
yes, we will certainly come back to that. Okay.
So I just want to carry over the key study to show that, food restriction really can have an impact on the brain. And when we think about traditional SSRIs to support anxiety and depression, oftentimes those medications are taking dopamine that the brain produces and kind of mobilizing it into a way that makes it more useful. And the reality is that in a starved brain, it's not producing the amount of dopamine that a patient needs in order to get the benefits from the medication. And so in order for those medications to really be effective, the brain needs to marinate in nutrition. We have to reintroduce food in order for our bodies to be able to produce the dopamine that we need in order to be able to kind of mobilize. So it's not saying that medication isn't effective, it's saying that medication in conjunction with nutrition is one of the things that we truly need in order to see a shift in our patient's mood and in their recovery. Other things that I will say is that, we think of that prefrontal cortex that is going to be beneficial in forward thinking and futuristic thinking. And oftentimes in our adolescent clients that are weight suppressed for an extended period of time might see a delayed development of that prefrontal cortex. So we kind of see some of our patients who get stuck in this place of not being able to think futuristically around where they're wanting to go. And so being able to really kind of help support the nutrition first, nutrition being the best medicine in our eating disorder patients, are going to then allow them to be more effective in therapy as well as in with medications.
All right, family involvement is absolutely necessary. And this is not just for adolescents. This could be for a college student or a young adult who is living at home, because parents really bring a wealth of important resources to treatment as well. Yes, this is something that the patient needs to work towards, whether that's weight restoration as well, but we also know that eating disorders, as we saw with the collaboration, is that eating disorders cannot be treated in isolation. So it really does require a village. We have tons of resources for parents and loved ones at Within Health. We'll talk about that very shortly here. We also know that parents do not cause eating disorders. We know that this is an illness that impacts the entire family system. We know that kids, any individual, no one chooses to have an eating disorder, just as no one chooses to have any sort of medical illness as well. And so really the recovery process will involve the entire family. And why we want to provide those resources as well is because the family system has been impacted by the eating disorder, whether that's months, whether that's been years, but they too will need to recover in this process as well. These are just a few things too. If you do have someone that walks into your office and you do have that opportunity to interview the loved ones, these are some things that you may want to ask about, or things that maybe they report to you that they are seeing at home. They may notice that their loved one is hiding wrappers. They may happen to be cleaning out a closet and find a bag of food wrappers that is stuffed into a secretive place. You may get, or they may get a call from the guidance counselor's office at a school to find out that, Johnny is throwing his lunch out every single day, whereas the parent thinks that Johnny is eating lunch because Johnny comes home with an empty lunchbox every day. So we do have to rely on some of these collateral resources as well for information when we are trying to make a diagnosis as well. You might find your loved one up in the middle of the night, sneaking in exercise. I know when I worked at the inpatient level of care, we had to monitor our patients in the evenings to make sure that they were not getting up and exercising in their rooms. You might notice that food might be disappearing. You might also notice that individuals are engaging in what we call food rituals. So they might be micro chopping food. They might be using strange condiments on something that maybe people don't normally use those condiments on. They might be limiting the types of foods that they're eating. They might be cutting out foods that maybe they previously used to enjoy. They might be lying about what they're doing. It becomes increasingly more difficult as well for families to eat together, to go out to restaurants, and you might start to notice, or they might start to notice that mealtime really just becomes a battleground. We also may notice that individuals are coming home, let's say from school, and saying, oh, I'm not gonna eat dinner with you all tonight, I already ate dinner. Which over time you may realize is actually not the truth. Or sometimes the individual starts to disappear after a meal, or they start using the restroom after every meal as well. So these are just some indicators that things might be happening. And this is just what we hear from parents sometimes, is that they really feel like a prisoner in their own home as well. You know, they feel that, especially if their loved one is in treatment or they're trying to get their loved one in treatment, they might feel that, you know, gosh, I can't leave my home because I've got to monitor my child. I've got to monitor my loved one. I need to know what they're doing. Parents might feel abused or victimized, and they might feel as well that the eating disorder really starts to manage the family as well. So families start to sometimes manage their lives around the eating disorder. And that's something too that we really want to suss out in treatment, is in what ways is the family accommodating the eating disorder as well. And so what we want to work on with the family is we want to really help them begin to understand the eating disorder. We want to really depersonalize the eating disorder. So what that means is we want to externalize the eating disorder and help the family understand that this is an illness. This is something that's really taken over their loved one too. And again, with that focus on not blaming the family, if we can also see the eating disorder as something as outside their loved one, it also helps to bring a lot of compassion and empathy into the process as well. We want to help the families understand that patients have that eating disorder self, that eating disorder part of their brain, and then a healthy self, a healthy part of their brain. And so that's also part of the treatment process, is getting that healthy self stronger to fight back against that eating disorder self. We want to work with families on communication and how to set boundaries. We want to work with them on messaging and languaging. The parents are, and the loved ones are, an important part of the treatment team as well. So we all want to present as a unified front. We all want to be on the same page as well. And these are just some of the things that, you know, eating disorders will say. It's almost like they have a script. You may hear a patient or a loved one say, you know, gosh, I'm really not sick enough, or I'm not as sick as those individuals in that program, so I really don't need to be in this kind of treatment right now. Or my parents are overreacting, I'm not ready to stop this. So it's almost like they're given a playbook. I remember when I again, back to when I was working inpatient, I'd very often get calls from parents or loved ones the first couple of weeks that their loved one was in treatment, and the parents would say, well, my daughter is telling me that, you know, she's not that sick in comparison to everyone else. And I'm like, okay, wait a minute, let's kind of talk about what's going on here. I think you need to come in for a family session. We need to kind of talk through this as well. And that's the eating disorder. You know, the eating disorder does not want to be in treatment in some of those initial phases as well. So let's talk a little bit about some of the special populations that we see. I really want to highlight the top 4. We have specialized. Ooh, okay. We have specialized programming. So I really am going to focus on the top 4. We have specialized programming for all the categories that you see listed here. We have specialty groups for LGBTQ+, men, since there was a question about mature adults. We do see individuals in our mature adults program, ages 30+. Some of them are getting treatment for the very first time. Many of them do not seek out treatment on their own because they feel that there's a stigma or that they will be some of the oldest ones in treatment. But we really have built such a nice cohort for them. Many of them have come to us from other treatment centers where maybe in the adult program, most of the patients fell into like that 18 to 22 range. So they are able to get treatment with us. And what we also see with the mature adult population is we tend to see more binge eating disorder. And then we also work very closely with the BIPOC population.
And so the last thing that I want to wrap up is that I'm also an eating disorder specialist consultant. And if you ever have a patient that's experiencing body image or eating concerns, I'm happy to be your phone a friend and helping them get connected to resources. Within Health is a network of Blue Cross Blue Shield of South Carolina. So it's one of the fewer higher levels of care options that folks have access to in the community. And even if your patient's needs extend beyond Within Health's abilities, whether that's getting connected to outpatient care or even finding inpatient options, don't ever hesitate to reach out. I'm always happy to help and support in any way that I can. And then these last literally minute that we have, do we have any other questions that are popping up or anything in the chat that we can answer?
And there's a QR code that should be popping up on your screen that you can scan, and that will give you information on how to refer a client.
Thanks for being here.
Yes, thank you everybody. I know we're like I know we got like right up to the 1 o'clock mark.
Thank
So
you so much. It was very, very informational, and I think probably a lot of people needed to hear that
yes,
information.
yeah. Well,
So,
thank you so much for
thank you.
inviting us, and we're
Yeah.
always happy to come back.